Welcome to Psychiatry Grand Rounds. This morning I have the pleasure of introducing Dr. Kara Boynewicz. Dr. Boynewicz completed her Bachelor's of Science at Eastern Illinois University, her Master's of Physical Therapy at Governor State University, and she also received her Doctorate of Physical Therapy at Governor State University. She is currently pursuing her PhD in Early Childhood Education at ETSU. She is certified in NICU Neonatal Network Scale Reliability. She is a faculty member on the Vanderbilt Leadership Education and Neurodevelopmental Disabilities Program and assistant professor in the Physical Therapy Department at ETSU. Please welcome Dr. Boynewicz.
Thank you all. Can you hear me okay in the back with my mic? Okay, so if you can't, just wave to me and I'll adjust. So I really want to appreciate your invitation for me to come talk to you about something that I feel passionate about, so I appreciate that. I do not have any conflicts or financial interest in anything that we will be talking about today. Some of the objectives that I want to discuss are up here with you, and then I've created an outline that we'll go through so it makes sense about what we're going to be talking about today. So we're going to start with the introduction, and I'll kind of tell you a little bit about myself. I'll tell you about the flow of the presentation, and then some of the main points that we're going to talk about. So really, the first section, we're going to talk about the scope of the problem, some of the prevalence in East Tennessee, and some of the long-term developmental outcomes for children that we kind of know and don't really know. Then I'll talk to you about what we do as a physical therapist in our NICU and some results of our study that we have done on some of the movement analysis of the infants. I'll talk to you about a couple of outcome measures that you can use potentially and how to refer later for therapy if you ever have identified any of these infants or families. So today I would like to introduce you to Kristen and Sam. They are two faces of the children that have been affected by the opioid crisis. We've had the privilege of taking care of them at Niswonger Children's Hospital. Diana has adopted them. She is our nurse manager, our pediatric nurse manager on the floor. She's actively involved in the foster program here in Tennessee for families that are caring for infants with NAS. Kristen and Sam have the same biological mom, but have different fathers. Their biological mom used a variety of different drugs during her pregnancy, and she had a pretty unstable life with some adverse childhood events, including, and then she also had adverse events later with incarceration, abusive relationships, poverty, and lack of prenatal care. So now we're going to discuss kind of the main point one, which is the scope of the problem, what NAS is briefly, and some of the known consequences. Is everybody at least a little familiar about what NAS is? Anybody that's not? Okay, just want to make sure. So just briefly, neonatal abstinence syndrome is one of the consequences that babies develop, right, from mothers that have been taking substances prenatally. So when the babies are born, they present with different types of withdrawal, so physical and neurobehavioral withdrawal after birth. So it's a multi-system disorder, and it affects the nervous system, the GI system, the respiratory tract, and these are where some of the concentrations are higher. And if babies have symptoms of it, it can lead to seizures or respiratory instabilities and some fluid loss. This is a map of Tennessee. So the darker blue areas on the bottom map, this is the rates of 1,000 births per babies with NAS. So in Tennessee, you can see the darker areas of the map. It's much more highly concentrated in our area of the state than others. Especially as you go more west, it definitely lightens up a lot more. So very heavily populated here. That top map just kind of breaks up the health classification systems for the state of Tennessee. And neonatal abstinence syndrome is a reportable condition in the state of Tennessee. So every time a baby is born with neonatal abstinence syndrome, it gets reported to the state. And then the state puts up together numbers on an ongoing basis. So this was the most recent one that I found. And if you can see on the left here, it's a little bit hard to see on here, but it just tracks all of the number of cases. And then these are the sections from here. And then this is the rates over the last 4 years. So far this year, as of November 11th, there was 867 cases in the state of Tennessee that were reported, total. If you look, we're right here, we're in number 1, that's Northeast Tennessee. In this area, 16% of all of the cases were reported, and that's 140 babies. This little area right here, that's Sullivan County. That had 8% of the cases, which is another 75 babies. So together, right there, that's a quarter of all of the babies born with NAS from the whole state in our area. And then if you add East Tennessee in, which is the Knox County, that's another 21%. So about 46% of our whole state with babies born with NAS is concentrated over in this area. So some of the effects on the fetus. So this is Sam when he was born. And there's some effects happen and some don't, it just depends. But they have about a higher rate of preterm birth. There's a higher rate of born small for gestational age, and when babies are born smaller than they should be at birth, they're at higher risk for developmental delays just over period. There can be feeding difficulties or seizures, and these are some of the risks to the infant. Some of the clinical features, what happens is that not all babies develop NAS, so there's a little bit of a difference. We call it like they're just exposed. So mom takes some of the medicines, and the babies still are getting that in utero. And then when they're born, some of them develop NAS, and then some of them don't. But it can start as early as the first 24 hours. The NAS symptoms can start. But it might not show up for between 5 and 7 days, the withdrawal, those severe withdrawal symptoms, severe enough to classify them into neonatal abstinence syndrome, not just like substance exposed. And so it occurs maybe in only half, but up till many of the infants that have these opioid exposures in utero, along with some polysubstance exposures. So some of the different symptoms that the babies display, it really depends on a few different things. So what kind of drugs that mom was taking. So the opioids are the ones that cause the severe withdrawal symptoms, but they can also withdraw from cigarettes or nicotine, barbiturates, those kind of things, and polysubstance abuse. It also depends when mom takes them. So if she's been on them for years, they're more at risk to develop NAS versus if she's only been on them a short period of time. The type of drug, some are metabolized differently in the mom and in the baby. And then how much the baby weighs at birth. So we do not have a good withdrawal scale for infants born preterm. So right now, it's kind of said that preterm babies don't develop NAS. What I think is that they have withdrawal. We just don't have a good scale to pick it up. And we'll talk a little bit about that on the next slide. So the main tool that we use at Niswonger and in the most of the country is called the Finnegan. So the Finnegan has 3 main sections. So it's got a central nervous system portion. It has like an autonomic respiratory section and then a GI section. So what happens is that they start using this after birth to score the infants every 3 hours or so. So we do a scoring period from the beginning of one feeding to the beginning of the next feeding on the babies. But symptoms can kind of be scored, somewhere in that time period that gives you one central score. At Niswonger, we have establish reliability for all the nurses and everybody scoring the babies, or to make it more systematically scoring, because some of them can be a little gray, and it's confusing for families about why babies are scoring, and they don't understand why some behaviors aren't just typical behaviors like sneezing or yawning, those kind of things. But when you have reliability, it's been shown in the literature that you have a decreased length of stay for the babies if everybody has had that reliability. So this is what we use there, and this tells us a lot of good information about withdrawal, but it doesn't really give me a lot of good information developmentally. So now that we've talked about what NAS is and how prevalent it is around here, I want to jump all the way to what does that mean, right? So we've looked at the literature a lot about what does that mean if they've had this, temporary condition, right? Because NAS is a temporary condition that goes away, supposedly, right? Because it can only last up to 6 months, the actual withdrawal. But does it have any longer term effects on babies or children as they grow? And I'll tell you that the evidence is confusing and says two different things. So I'll just kind of summarize it for you a little bit. This looks at, this slide just kind of gives you a snapshot on what we say about environment, cognition, and brain structure. So they did some brain imaging of babies that had been opioid exposed, and what they found is that there's really no clinically significant differences between the babies exposed and not, except in the basal ganglia. So for us, the basal ganglia is very important because it controls movement as a therapist in movement analysis. When they did some diffuser tensor imaging of some of the pathways developed in young children that had been exposed to opioids versus a control group, they really didn't find a lot of statistically significant differences either, except in one of the tracks, which was the superior, it was the superior longitudinal fasciculus tract. So that track connects the area of the brain with the premotor cortex, and also has a visual motor, and motor sensitivity, and it also connects the parietal and occipital for attention, working memory, and language and emotions. So with the environment, there's been quite a few studies too that said, well, okay, you're seeing some of these delays in these babies when they're 6 months, 9 months, but if you try to control for environmental factors, such as frequent maternal absence or low socioeconomic status and all that, it seems to kind of outweigh those. So we need to be careful when we're examining the literature that we're trying to control for the variables in the environment, which can cause some of those delays in the first place. And then some of the cognitive differences, there's a nice mix of people that says it does and doesn't over time. It depends what study you read. This longer term study I'll talk about in a little bit, but this is out of the Netherlands, and she followed the children until they were 8.5. So she tested them at 1, 2, 3, 4.5, 6, and 8.5. On the Wechsler was her primary one she used. And what she found, and she had a group of children that were exposed, and then a group of children that were in foster, and then in a control group. So what she found is that here's the boys. So they were delayed right from the beginning at the first year, and they were kind of consistently delayed over time without really getting any better compared to the control group. Here's the girls. They seemed to be doing fine in the first few years of life, and then as soon as they got older, here's 4.5, and then here's 8.5, their delays didn't show up until later in the opioid exposed. Now, that's just one of the studies. There's some that say there was no difference over time, so. Oops, I'm sorry. So when we think about all of our ACEs studies and what we know now about all the adverse events in childhood, And you think about how can it not cause some, because our babies are born and they automatically have an ACEs of 2. They were born substance exposed, and they were born with a mom that has an addiction. So right from the bat, they're starting off with that. But then there was another long-term study over in Australia, and he followed them into high school and looked at their performances over time. What he found, and this is this one right here, he found inconsistent findings. So he did not find what the lady in the Netherlands did, is that kids don't kind of catch up over time. And even if they're in a foster who she controlled for, they still are lower than ones that were not exposed, period. He also studied children that were in foster as well. He said that they usually catch up within a year for weight, height, head circumference by 2 years. For their behavior, he said they found like hyperactivity with some short attention spans and memory and perceptual problems. For their cognition, it was inconsistent. He said the cognition was inconsistent findings with lower scores, but really no difference compared to the controls. And that their school achievement was associated with progressively lower school performance, but still within that normal range of school performance. And then we have a systematic study over here done by Sunderland, and they only found 5 good articles that they said met their criteria for their meta-analysis, and they found no statistically significant differences out of reviewing those 5. McGuire said she did, and so did Ballacino. Just to let you know that there is a lot of conflicting evidence out there, so you know that when you're trying to help guide families about what to do or different things, it's hard to put something on there. What we do know is that there is a lot of vision issues with children that have NAS, and this ranges from anything from like strabismus or nystagmus to visual perceptual problems and visual motor problems. So what I take from that is it's going to be hard for them to learn and write from the board like we still do in school, right, if you're having this visual motor perceptual problem. This map is just a map of ACEs scores through the United States, and we are concentrated high, the highest in one in the country in Tennessee. Last studies I'll talk to you about, which is going to transition us into what we do in the NICU, is some infant mother studies. So we do know that there is feeding difficulties with infants, and that infants spend almost as much time in fussing as they do feeding. So that's hard for moms and families, because that's a big primary role of a mom or a caregiver and an infant is to feed. We also have found that neurobehavior difference is also highlighted in regulation, and quality of movement, and higher stress abstinence scales. So that's proven in the literature. We know that was found. We also found that within mother-infant interaction, that it was lower with moms that were substance, or lower in babies that had substance exposure. We know from the literature that moms experience uncertainty, fear, and stress while their babies are going through withdrawal. And what we do know is that healthcare providers have this really limited and lack of, not all, have sometimes a limited and lack of understanding of this trauma-informed care to help the moms and support the moms and the babies together. So on to what we do, and then I'm going to talk about what we're looking at in babies, and then tell you what we found from our retrospective study. So here's our order set. So we are part of the NAS protocol at Niswonger, so all babies that have NAS are supposed to get a physical therapy evaluation. So if they have a Finnegan score of 8, they are suspectful of NAS. So sometimes we get a referral to help with the neurobehaviors and the calming. Sometimes they just go home and they can make it. Sometimes they keep getting higher scores and then they're sent to the NICU. When that happens, the whole order protocol gets in place, and we start with, non-pharmacological management, soothing, rooming in, those kind of things. The opioid, the morphine for the controlling. Okay, so who knows exactly what a physical therapist does with a baby? Yeah, I did. Yeah, I get that question all the time. So I'm going to briefly tell you what we do so you have some kind of conception, because most people can understand what we do with adults, but most people are like, why does a baby need a physical therapist? So we do our physical therapy eval, and some of the main points we look at, it's very specified for neonates, usually for preterm babies, is the main focus, and then now babies with NAS. So some of the things you can imagine we look at, cardiopulmonary, how they're breathing, their heart rate, those kind of things. Some feeding, those are kind of obvious. We look at neurobehavioral organization of infants, and what that means is that we really look at the state that the baby's in. So babies go from sleeping to drowsy to awake to fussy to crying. Those are kind of like the states. So we look at what kind of states they're in, how quickly they're going from the states, trying to get them into a good state so they're ready to feed and interact. We also look at some of their behavior cues, so their stress cues, their disorganized cues, and help them with their regulation cues so they can help interact. Oops. We also look at their skin. Babies can have skin issues with NAS from if they're having a lot of loose stools, which is a common issue, then they get a lot of diaper rash or excoriation from rubbing. But they can also, their skin can tell us behavioral cues if they're changing, modeling, those kind of things. We also look at, musculoskeletal-wise joints, muscles, those kind of things. We also look at the neurological system, some neuromotor pieces. And then we look at, so you can't really do strength testing in a baby like you would an adult, so we call it postural control and quality of movement, and that's how we judge movement systems. So we have started this big retrospective study here, and we are studying the charts of infants and moms retrospectively for the last 5 years. So out of our first 150 charts we pulled, 122 of them had physical therapy evaluations. Out of those, 104 were full term. So for this talk, I'm just going to tell you about these healthy, full-term babies, not the preemies or ones with super medical complications. So if we look at, when we look at some of the maternal and demographics, what I can tell you is that most of the moms were between 25 and 29. The second biggest subpopulation was between 18 and 24, so we're talking about younger moms. 23% had beyond a high school education, 51% had a high school degree, 25% did not have any, didn't finish high school. 78% were single. 78% were not employed. And 63% either had a history of mental health or were taking a medication that were commonly used to treat a mental health disorder, out of the 104 for here. Most of the babies were 39 weeks at a healthy weight, APGARs of 8 and 8, pretty full to healthy. When I looked at just some of the drugs moms were taking, correlated with, so an increased length of stay with these babies is that they were on buprenorphine or a benzodiazepine. And one of the only other correlations that came up was that if mom was taking a benzodiazepine, it was also positively correlated for marijuana. So one interesting finding, I'm not going to go through everything with you to bore you, I'm just going to tell you about some key findings we found. So one of the things we look at is called the popliteal angle. So all this is just this little angle behind the hip and the knee of the baby. So what this does is that it helps us determine how mature the baby is and how much tone is in their legs, which we want them to have. This item came straight from the Hine. So the Hine is the Hammersmith Infant Neurological Exam. This is just one of the pieces of it. So a full-term baby that's 39 weeks, which was normed on the hind, has usually a degree between 90 and 100 degrees right here, this angle. So preterm babies are going to have much larger angles. So we found that 79% of our babies had less than 90 degrees. So what that means is that they have a significant increase in muscle tone in their hamstring muscle, which could affect their range of motion. And when I think about it in the mom's point of view, trying to get them dressed, trying to have them diaper, trying to clean them up, those kind of things. Two other things we found that were significant, I thought, were from our neuromotor section. Again, these were they're just straight from the hind. One is called a arm recoil and a leg recoil. Oops. So an arm recoil is just when the baby's arm is up, you stretch it down and you see how fast it comes back up. So on a full-term baby that's 39 weeks, when you bend it down, it should completely return quickly and fastly. So we had, oops, I'm using the wrong one. So the infants with NAS, 46% had arms and 50% had legs that were difficult to extend and forcefully snapped back. So again, telling us a lot of tone in the extremities, constant firing of the muscles, probably from the irritability of the withdrawal, but not a typical finding. So then I went to the literature and I was like, okay, what does this mean? I have to find out, when they norm this, what does this mean if these infants had this like high category? And of course there's nothing there because there wasn't enough to report on. But it is an atypical finding on the hind as well. So when we started looking at at their state regulation, so we want babies to slowly wake up and we don't want a baby to go from sleeping to crying. We want them to wake up. If you're not in this quiet alert state, it's really hard to participate in feeding. We know they have feeding difficulties, interacting with mom, those kind of behaviors. So what we found the most is that the infants, the biggest category was this abrupt state change. So over half of them had this quick, abrupt change. So they were quickly moving from like crying to sleeping, or they were like, kind of lightly asleep to like irritable. And then the green was a diffuse state, meaning they were really sluggish. It wasn't moving along very well. They only had like two states, so they were either irritable and crying, or they were like sluggish and drowsy. And then some can and do have this nice smooth quality. We also started putting some of the stress signs together. So what was correlated is that babies that had this like rapid state change also had some stress cues of irritability and this panicked alert. And then babies, so we either classified those as irritable babies or avoiding babies. So these kind of babies had this really diffuse sleep state, not many changes. They had this glassy-eyed look. Well, they could have been over-medicated from the morphine too, from that one. They had this lack of alertness, or they had this averting gaze. And this is what's most troublesome the most. So an averting gaze is when a baby is in a nice state, and your mom's talking to the baby, and you're seeing how the baby's doing, and they're looking back at you, and then they turn away. So they're not shutting down, they're not going to sleep, they're actively, like, it's avoiding you because they can't handle all of the stimulation in the environment. So those ones are hard to explain to mom, that your baby really doesn't not like you, your baby just needs a break, and it has to settle down whatever they feel in their body. So then when we took a look at the behaviors, let's see if this one works. I was going to show you it didn't work, the videos, what a disorganized movement is. So the highest response rate is that these babies had this really high levels of disorganized movement patterns. They also had facial grimacing and finger splaying and arching. So those were the behaviors, stress behaviors that we were most noted. And then we looked at quality of movement. So that means, how does a baby look when they're laying on their back kicking their legs? Can they start to hold their head in the middle? Can they bring their hands to the middle so they can start sucking on their fingers, which calms them down? So when we looked, we kind of categorized these two. They either had this like jittery, jerky movements, these random, wild, uncoordinated movements, Some did have some smooth movements, or they had these cramped synchronous movements together. These are just the interventions that we did. So we mainly do family education and home programming to work with the families, but we also do some functional activities like get them used to diapering and changing their clothes, and also some handling techniques to get them to calm. So when we grouped all those together and we started trying to look for we're looking for some patterns of what we found. When we found is that the babies that had more disorganized state cues, so these were babies that had a lot of stress, these were correlated with poor feeding, decreased postural control or strength or control of the baby's body, and this jerky and jittery motor quality. And so then we started looking, okay, so what did the babies that displayed this nice regulatory behavior did? And so what we found is that these babies that were more regulated did have smoother quality of movements and were negatively correlated with this jerky, jittery quality of movement cues and these avoidance cues. So what was the most interesting finding when we started putting all these pieces together was that random, uncoordinated movements were actually correlated with better postural control and decreased length of stay. But the babies that had a lot of stress cues and that were disorganized and irritable and with poor feeding had longer length of stays. Those are the ones with the avoidance cues in them. So there's also standardized outcome measures that we can use in the NICU. So that was just like, when you're doing your evaluation on your patient and you gather all your information and then you decide if you need to use a standardized test. These are 2 standardized tests that you can use. One of them focuses more on neurobehavior. It's called the ENS. The other one focuses more on postural control, which is called the TIMP. So the ENS is the Brazelton for preterm infants and infants that are substance exposed. So this is pretty well researched by some significant researchers with infants and caregivers. And it is a slight modification of the Brazelton. What it does, and when you finish giving this test, it looks at different things like the attention of the baby and the arousal and how the baby does when they're handled, meaning like, can you move them? Can you change their diaper? Can you put their clothes on and off? How excitable are they? Their quality of movements, are they smooth? Are they jerky? How lethargic are they? It has a stress abstinent sign category, and it also looks at infant reflexes. Oh, and I was going to show you what consolability is, but the video didn't show. So consolability means we try to help the moms console their babies in a way that makes sense for them. So using a process or a step. So instead of just sticking the pacifier in their mouth and swaddling them really tight, we use steps. So like first you use your face and your voice, and then you put your hand on them, and then you pick them up so they learn to kind of regulate themselves. So the TIMP is just a different one, and that looks more at postural and motor control, not as much at state. Even though the tests are actually very similar to administer, they're interpreted vastly different. So this gives you how they're holding their head, and what are they doing when they're laying on their bellies, and those kind of things. How's their kicking look? And so this was validated to help identify infants that have a motor delay. That was the purpose of this test. And it's got good research behind it with good validity and reliability. It also is a nice parent training tool, so I can show them, oh, your baby's already doing this, and this is going to be the next steps to do. Try to work on this with them. So it's a nice training tool to use for them. But right now we don't have a good standardized outcome measure to use on babies. So the ENS is the only outcome measure that I have found in the literature that is actually normed for this. However, when I got trained for it, it is very tedious and cumbersome to score, so it's not very practical to use, like as a clinician in the environment. It's not as feasible. But then NAS is also an automatic qualifier for early intervention. But we can't just automatically, I mean, I guess you can, but like if all those babies actually really got into that, like we would overflood the system and we wouldn't really know who needed the therapy and who did not. Oops. So clinically, I can tell you that before I had gotten trained in the ends, I had done the TIMP on the babies, fully expecting them to have better motor control because they had all this tone. This is not part of the retrospective study. This is just clinically. But when we did the test, there was about 33 of them. 63% were not typically developing for their motor. So I think their motor can be a predictor of later things maybe to come. Because as you know, when we reviewed the literature, motor is not one of the things that is a residual like side effect of an opioid exposure. It's more, processing and memory. And so here's an example that I did in the hospital. So this baby, term baby, high APGARs. Mom had Subutex. Those babies tested positive for Subutex. Mom is a 31-year-old, so G7, P5, 5 other kids. She was on 8 milligrams tablet of Subutex and 12 sublingual. Sorry if I'm saying these wrong because I'm not very familiar with how the medication. She was on 400 milligrams of Neurontin, Zoloft. She smoked, and she had Hep C. So a lot of issues with mom prenatally. But when we did the TIMP, I did a TIMP and an ENS on the baby to see what it showed and scored, right? So the baby was in the low average range, so a little bit delayed, but not terribly motor-wise. And then we did the ENS, and the baby showed deficits with attention and handling and stress. Those were the 3 red flag areas that we found. And so my reflection of this baby is that a higher at-risk mom, but a more capable baby, right? So the baby does have calming strategies, is not super fussy, irritable, but has a decreased ability with her head control to focus. So if mom is at higher risk and baby is not great with motor, what's that going to show mom the cues that the baby's interacting with mom and the care, long-term care for the infant. So maybe a referral for intervention. Here's another example, just one other example. So this baby was there for a longer time, and this is serial testing. So the baby had one done at 2 weeks old, a TIMP and an ENS at 2 weeks, and then a TIMP and an ENS at 4 weeks. So this is a full-term baby, a little bit lower APGARs because the baby had meconium after birth, but then didn't need oxygen or anything like that. Mom really didn't have any prenatal care. She was a G3, P2, so she had 2 little kids at home, and was only on 20 milligrams of Subutex a day, or daily. At the time but mom was not there very often while the baby was withdrawing because she was at home. She had like a 18-month and a 2.5-year-old. But this baby scored in the below average range, so 1 to 2 standard deviations below the mean for their motor control at 2 weeks. And then their END scores, poor in handling, arousal, very excitable, doesn't have any low tone, doesn't know how to calm, has extreme stress scores. So the baby was on 0.1 milligrams of morphine at this testing. So 2 weeks later, before they left, we did the tests again. Now the baby increased in score, but it was still in the below average range compared to other infants their age. And their end score stabilized a little bit, so not as many reds, but this baby is still, he doesn't tolerate handling, like changing his diaper was hard, putting a new onesie on him was hard. And even though he appeared strong, we know his tone and his posture was off. So this mom is going to go home and try to interact with this baby who's super irritable and fussy and can't figure out how to hold his body in space. So I would say that one probably for sure would need a referral and some intervention because he's really struggled to calm down. So this wasn't originally part of the talk, but I can just tell you if we have time, if you were interested in what we do in there, if you were wondering. I can tell you that from, we want every mom and baby to look like this, right? But the reality is that most of our moms and babies look like this, and they're both distressed out, especially in the hospital setting while their baby's going through withdrawal. Most of them say they don't understand the risks of NAS, they're not aware of it. They think that sometimes why are we making their baby a drug addict by giving them morphine? They don't understand the scoring criteria. They don't feel confident in their parenting. They feel judged by some of the nursing and the staff in the hospital because, they're doing the right steps, or trying to get the treatment, they're doing what the doctor said, but then they're still getting judged by everyone in the hospital. Half the time they hide the fact that why the baby's there, so they don't let the rest of the family come up, and they limit access to like grandparents and aunts and uncles. Some want to talk about the trauma and what it's like. Some don't want to talk about it at all. So it's a wide range. So what we do is we do a lot of non-pharmacological management. So rooming in has been shown to be very effective for infants that have neonatal abstinence syndrome. So we actually built and created a whole wing in Niswonger. So the baby's in there, and then there's a pull-out couch for mom, and they have a shower in the room. So mom, caregiver, dad, grandma, whoever it is, rooming in, has a shorter length of stay, breastfeeding. What we don't know about breastfeeding is that I think they originally thought it was the breast milk. And then some of the more recent studies have shown that because when they looked at they called it breastfeeding, but it was just expressed breast milk. So we don't know if it's the actual act of skin to skin, putting your baby with an attachment piece like on your skin, or if it's the actual breast milk. So either way, if they can't breastfeed, I just say, okay, we'll put them on your skin. Rooming in, acupuncture they found, we don't do that here, but babies have lower stays, lower scores, less agitation, and we have a whole protocol for that. Swaddling, dimming the lights, modifying the environment. Here's one of our rooming in rooms. We have, these are called mamaroos, so they have a semi-reclined place for the baby to stay if they don't want to be laying flat or the moms can't hold them. And we do a lot of education on the scoring, some of the environment, how to massage and touch your baby because they're so stiff or they get really irritable with changes. We do a lot of interpretation and responsiveness to the infant's cues with the moms on how to interpret that to help them. And then there's a whole packet they get about how it works in the NICU and how to support their infant. Really focusing on like the touching and the bonding, learning how to touch your baby slowly so you're not using, if they're already irritable and you're using these quick things and you're really nervous and to touch the baby, to do it really slow. We teach them infant massage to help care for their baby. Infant massage is actually shown to be good for the moms too because it decreases their stress levels by performing it on their babies. It is an effective intervention for babies in the NICU if it's done by the mom, not by me coming in to do it. I mean, I'm sure it can probably help temporarily, but more from a caregiver. We do a lot of swaddle bathing, so we wrap the babies up in blankets. We put them in the warm water. I don't know, this is from the preterm literature, but it seems to really help the babies over there. I don't know if they have the typical like leg cramps that adults get when they go through withdrawal, so I don't know if this warm water helps them, we can't ask them, so we don't really know. Or I don't know if that's the tone in the legs, that kind of stuff. In early intervention, so we know that we need to put these neuroprotective factors around them, the babies and the families. So they automatically qualify. I really don't know the numbers on actually how many make it into early intervention and then how many actually sustain the early intervention, which is the Birth to 3 program in the state of Tennessee, just to help monitor them. We had written a grant a few years ago to try to get a NAS follow-up clinic, but we didn't get it. There is one in Knoxville, so they're tracking some outcomes of babies born exposed. But what we really need to do is work on the proper parent engagement, because 90% of our infants go home with their biological families. So I'll just leave you with, the babies are born already with ACEs scores, so they're already at risk to develop some adverse events. And we also know that there is genetic studies undergoing about some of the environmental and factors that all play into the epigenetics of what the infants are forming. Excuse me. So that can be tricky as well. And I'll tell you that one of our babies born full term did not have NAS, and then they needed an abdominal surgery. So they needed, had to have the morphine or, the fentanyl, whatever. So then they actually developed the NAS after the surgery. So I don't know if they were more at risk because mom used prenatally or if it was just a fluke. But I'll give you a little update on Sam and Kristen, where they are now, and then I'll leave a couple minutes for discussion. So here's Sam, and he's now 4. So he attends daycare. He loves being outside and likes to play with tractors. He participates in gymnastics and a music class. He had a 2-week stay in our NICU, and he used morphine. He also had an HIV exposure and had antivirals for 6 weeks. He also had torticollis, reflux, and feeding problems as a baby. And his current health conditions include a sensory processing disorder and cognitive delays. When he aged out of EI, his family took a break from services, but now he is back in school therapy services for OT for sensory processing and speech for poor language. And his family also participated in a 16-week parent-child interactive therapy program. Now here's Kristen. So she is 5. She participates in a homeschool kindergarten dance class and loves mermaids. She was in the NICU for 7 weeks. She had 1 seizure and that was related to NAS. Her pharmacology course included morphine and phenobarb. She started early intervention when she was 5 months. So she was in PT till 31 months old because she had plagiocephaly, which is the flat head. So she wasn't moving a lot. Increased muscle tone, poor state control, and feeding issues. She was evaluated but not meet the criteria for a helmet, which is the little things the babies wear. She also received speech for feeding. And nowadays, her mom describes her as always bored. At 2 years old, her daycare providers identified that she always needed to be entertained and loses interest quickly in activities. Her mom describes her as lacking empathy and compassion. She also described as short-fused. She's had some behavior issues, and her family is seeking out counseling and a formal mental health evaluation. So that's it. So some words of wisdom from Diana, her mom, just says, don't treat us as a cookie-cutter plan. Make sure all the medical comorbidities are ruled out, reflux, pyloric stenosis, feeding difficulties, those kind of things. And what works today doesn't always work the next day. And to make sure you have a good, healthy support system surrounding you if you're going to help adopt an infant that has NAS. And that is it. you guys have any questions for me about anything? Yeah.
Well, thank you very much, and I appreciate the work that you all are doing. This is such a big problem. My question is, I know there's not much literature, but from what you've looked at, is there any effort to differentiate between the long-term consequences of exposure to opiates versus NAS, since not every baby gets NAS?
Right. No, no, there's not. We had put in 2 grants to follow the babies, and we were going to have 3 cohorts, one as a control, one that was exposed but did not develop, and the third was NAS. Because I don't think there's been a lot of studies that look at the differentiation between exposed versus NAS. Because in my thought, I'm like, well, they just developed this temporary condition. How is that different than the months of exposure that they got in utero? But right now we're not focusing on the babies that were just exposed. They don't qualify, they're not automatically referred. That's a good question. Oh.
So, Kara, you showed some good psychometric data for the temp. I was wondering, in terms of the Finnegan, do you have psychometric data you could share about its reliability, validity, sensitivity, specificity, internal consistency?
Yeah, sorry, I did not put any of that in, but the Finnegan has been shown with good reliability and validity as a withdrawal. There's actually 5 or 6 withdrawal scales out there, and the Finnegan is one of the most studied and most valid and reliable tools that we have, which is probably why it's the most commonly used across the country. What I was trying to get was the individual Finnegan scores to try to correlate that with some of the motor scores. But the way we are pulling the data retrospectively from the chart, sometimes it's impossible to get what the individual scores was. I think I forgot to mention that the most common, and we do have some of the data from some of the Finnegans, but not all of them. So the most common score reported was increased muscle tone, mild tremors, and a startle reflex, which is when you put the baby's head back and they kind of jerk. So they seem to all be related to the central nervous system, which is more correlated with what we do motor-wise. Anybody else? Well, thank you all again today for letting me come and talk to you about NAS.